Good morning. We move to the next roundtable on no-ST elevation acute coronary syndromes from diagnosis to management in 2014. Dr. Xavier Bosch and I would like to welcome all those attending and to thank the speaker for being here. We have the privilege to have with us three important doctors to speak about this issue. The schema of the roundtable will be independent talk of 20-22 minutes, followed by 5 minutes of discussion. The first speaker is Dr. Christian Miller, Department of Cardiology, the University Hospital Basel, and Assistant Professor of Medicine in the University of Basel. Dr. Christian Miller is an Associate Professor and Head of the outcomes research and process at this university. He has been working in markers of plaque instability in the early diagnosis and risk stratification of acute myocardial infarction. His talk this morning is what is new on biomarkers for the diagnosis and risk stratification of acute coronary syndromes. Thank you for being here.
So, dear persons, dear colleagues, it's a great honor and pleasure for me to give you an update on cardiac biomarkers. I also explicitly want to thank Alessandro because so he's involved with some team members in the research, and so I'm very thankful to give you this update. I come and work from Basel. It's a small medieval town. It's very nice, particularly due to the river, which is extremely attractive in summertime because it can be used for swimming. I'd like to highlight to you that biomarkers are essential clinical tools for us as cardiologists that we have to know, and we have to know how to use them. So I will try to highlight aspects that you in your clinical practice I think will need and have benefit once you're back at your institution. So my potential conflicts of interest, I'm able to share some of our own research. Our research is mainly funded by public organizations, but we also have intense cooperations with the diagnostic industry. The most important disclosure is on this slide. So we do clinical research. So it's a team endeavor, and I'd like to clearly acknowledge the great help of these fantastic research fellows I have the great privilege to work with. And then there's one conflict that I also have to address, and it's a conflict that came apparent Wednesday night. So I was born in southern Germany, and I went to Munich University. So I have to confess the conflict that likely on Wednesday night at 9:04 p.m. I likely had different feelings when most of you in this room, when realizing that Karim Benzema scored this great goal. And so the team in white, I strongly assume that most of you favored the team in white, clearly won the first game. The agenda for my talk is I'd like to start with a case, then highlight to you what was the standard of care during our training and also the last couple of years, and which biomarker we really have to learn how to use in the year 2014. And also what biomarkers have taught us recently about the pathophysiology of patients with ACS. A simple case, a gentleman that presented to our emergency department with a combination of dyspnea and chest pain. The episode occurred more than 6 hours ago, so it's important to remember it was a couple of hours ago. It was about 30 minutes, no radiation, no sweating. The patient never had angina before during exercise. He was completely asymptomatic at the time he came to the emergency department. His history was remarkable for having hypertension because, however, he didn't feel anything like many of our patients. He stopped the antihypertensive medication. and he presented with a markedly elevated blood pressure and otherwise normal vital signs. Of course, we did the ECG in the emergency department, and I assume you would agree with me that the ECG is normal, so there are no clear signs of ischemia. Then, of course, the next thing is to do cardiac troponin testing. It's difficult to see, so at that time, it's a couple of years ago, and I think that might have been the test that available a couple of years ago to your institution, so the 4th generation troponin T, CK and CKMB. And we did serial testing at presentation, and because he was entered into our diagnostic study, we also had levels at 1 hour, 2 hours, and 3 hours, and all of them were completely normal. So the patient was completely asymptomatic during the 7-hour stay in the emergency department. The second ECG was performed, and it was also normal because the physician also thought of pulmonary embolism. He checked D-dimers. D-dimers were also normal, and the chest X-ray was performed. It was also normal. So everything was okay, and then, of course, a management decision has to be made and what to do with this patient. So I'd like to hear your thoughts. What would you have done? You would have admitted the patient for echocardiography, for an exercise test, or directly for coronary angiography, or you felt this patient should be managed on an outpatient basis and to schedule one of the exercise tests in a couple of days. So may I have your thoughts? Who would admit the patient for any of the procedures? Would you admit the patient, or would you preferably manage him as an outpatient? Who would admit the patient? Please raise your hands. Okay, about 50% would suggest to admit the patient. The other 50% perhaps as an outpatient. That's what we did, but we were not really happy with our management. So the same patient presented again. He was kind of discharged. He had scheduled an outpatient exercise stress test, and 4 days later he came back with a more intense chest pain episode, at that time radiating to the left arm and to the back, and the ECG at this time point was much more impressive. So he had an ST elevation myocardial infarction just 4 days after he had presented to our institution with a chest pain episode that was shorter, that it was not as severe, and that had a completely remarkable ECG and completely remarkable cardiac biomarker at that time. So of course we were very frustrated because we were not able to prevent that event. However, as he was entered in a clinical study, we were able to go back and use the samples that were obtained initially and to check them with the more sophisticated, sensitive or high sensitivity troponin assays. And here are the results. So you remember all these numbers that were available to the clinicians, and here are 3 sensitive or high sensitivity cardiac troponin assays. And they indicate clearly that the initial episode that was missed by the conventional troponin assays could have been easily identified as an acute myocardial infarction if any one of the sensitive or high sensitivity assays would have been clinically available in this patient. So there was a clear rise in the Siemens Ultra, a clear rise in the high sensitivity assay, and there was a clear rise in the Roche high sensitivity assay. So this is a case presentation to highlight to you that the use of sensitive or high sensitivity cardiac troponin assays improves the early rule-in of acute myocardial infarction. The standard of care in the last decade was very similar to what it still is now. Of course, biomarkers only complement clinical assessments. They should be only used in conjunction with the full clinical assessment, in conjunction with the ECG. In those patients who have clear ST segment elevations, we have a fantastic pathway installed in all our institutions, and of course biomarkers are not really necessary in these patients. However, unfortunately, on their own, the clinical assessment is rather inaccurate, and the ECG in the most patients who do have an acute coronary syndrome does have no changes at all. So we really rely on the biomarkers for additional help. During my, and I think also during your training, CK, CKMB, cardiac troponin, and myoglobin were the biomarkers that were available and used. Starting in the year 2000, troponin really became the predominant player. It was the universal definition of myocardial infarction that for the first time stated in the year 2000 that cardiac troponin should be used as the preferable marker of cardiomyocyte damage. So it's a very good marker. However, the conventional assays that you were used to a couple of years ago and I was have one key limitation. And the limitation is the troponin blind interval. From the onset of acute myocardial infarction until levels of troponin become detectable in peripheral blood, it takes about 3 to 4 hours. And that key disadvantage led to the standard of care all over the world that the troponin measurement has to be repeated after 6 hours, and all patients with suspected acute myocardial infarction have to stay in the emergency department for 6 to 8 hours in order not to miss the troponin rise that would occur only a couple of hours later after the onset of acute MI with the troponin assays available at that time. Of course, this is a very, very ineffective procedure because all those patients who have benign disorders do have to wait in the emergency department for many, many hours until the second measurement of troponin can be done. And this, of course, is very expensive and also bad for the patients and bad for the emergency department because it contributes to the overcrowding in the emergency department. So what have we learned recently and what are the biomarkers that you should really know about for your clinical practice? When considering the pathophysiology of atherosclerosis and acute myocardial infarction, we know that plaque rupture and thrombosis at the plaque site is the first event to occur. So many of us in this room have, and many of course also of you have worked with inflammatory biomarkers or biomarkers that are associated with the early event of plaque rupture. So Tony has worked with it substantially. So do these early markers of plaque ruptures help us in the early diagnosis of acute MI? These are findings from our data set, but many others have confirmed these findings. If patients present with acute chest pain, the diagnosis that can underlie acute chest pain can be summarized into acute MI, unstable angina, cardiac diseases other than CAD, for example, myocarditis, tachyarrhythmias, hypertensive heart disease, or non-cardiac diseases, or those patients in whom we are sure they do not have acute MI, but we cannot specifically define the cause. We tested multiple of these markers of plaque instability, including myeloperoxidase, MRP-814, pregnancy-associated plasma protein, and CRP. However, as you can see, there's a huge overlap in these box plots between patients with acute MI and the other disorders. So to summarize this for us as clinicians, all of these very interesting biomarkers, they are completely useless for clinical practice for the early diagnosis of acute MI. Also, they likely represent things that happen in the myocardium, not necessarily in the coronary plaque. So they are useless for us as clinicians. So we really likely have been distracted by all the fancy pathophysiology of plaque instability. It's not useless. Like perhaps in other aspects in life where it can be extremely dangerous to be distracted. Also, I think for our clinical tools, we really have to focus which tools are those that provide clear help for patient management. And in fact, it's only one biomarker that you really, I think, should know the details about, and it's still cardiac troponin. And to be more specifically, it's the more recent generation of these assays, the high sensitivity cardiac troponin assays. There are only, I think, two exceptions to the rule. CK-AMB is still extremely helpful when talking about early reinfarction because troponin has a prolonged release from the myocardium, whereas the CK-MB drops much more rapidly, so CK-MB is still the best marker for early reinfarction. And perhaps the only other biomarker that I think is ready for prime time is copeptin for some added value for the early rule-out of acute MI. But it is a troponin world, and it's troponin, and it's important for you to know how to best the troponin assay to best use the troponin assay that you use clinically in your institution. So what are the specifics of a high sensitivity assay as compared to the conventional assays most of us have been trained with? A very good but conventional assay is the 4th generation cardiac troponin T assay. Many of us in this room still have, if we have used it, remember that the cutoff level that was initially used was 0.1. That was the cutoff level when troponin was introduced, and it's the cutoff level that provides similar sensitivity to CK&B. However, then the new concept was introduced, how to define a cutoff level, and the cutoff level then recommended was 0.035 because that's the cutoff level above which the assay itself is rather precise. Then there's an area between 0.01, between 0.035, where the assay has huge imprecision, and there are levels below 0.01, which were considered normal. Now, with the new tests, the high sensitivity tests, we have learned that what we previously considered normal was in fact elevated in some of our patients, like the patients that I presented to you from the case vignette. So this patient, in fact, did have an elevated troponin level that was just not captured by the inaccurate old generation of tests. He had a clear myocardial infarction, a small myocardial infarction that can now be detected with the high sensitivity methods. So the features that are different with the new assays is the high sensitivity methods detect cardiomyocyte damage that was undetectable with conventional assays. So if you want to avoid the mistake that we did with our patient, because we didn't have the test clinically available, and if you do want to diagnose also small myocardial infarctions, you do need a sensitive or high sensitive troponin assay in your clinical practice. The use of this test also is extremely helpful to identify those patients at highest risk of dying. Troponin is so important because it is so closely associated with the risk of death, and the high sensitive methods are even more accurate. So just taking about 1,000 patients who present with acute chest pain and splitting them in groups who are normal for troponin or have elevated troponin with the 99th percentile used as a cutoff, there's a huge difference in the risk of dying. Patients who are normal for troponin have a risk of dying within 1 year of 1%, while the risk is 10% in those patients who have an elevated troponin. Of course, you know this clinically, but the magnitude of the increase is important. It's not a marker that tells you the risk is doubled or 3 times or 4 times. It's 10 times. So if you are normal for a high sensitive troponin, your risk is extremely, extremely low. So this is just a differentiation being troponin positive or negative. You can do the same thing in differentiating the entities, acute MI versus unstable angina. Patients adjudicated to have acute myocardial infarction do have 7 times the risk of dying as compared to patients who are adjudicated to have unstable angina. And I think this insight has important implications, and I'll come back to at the end of my talk. Of course, then the case vignette is only the example, and here are the scientific data. We had the privilege to publish them in the England Journal of Medicine, and Tobias Reichlin was the first author of our data set, showing clearly that high sensitivity troponin assays improve the early diagnosis of acute MI because they do have higher diagnostic accuracy at presentation. Diagnostic accuracy is quantified by the area under the ROC curve. In black, you have the standard test, the 4th generation troponin T, which for all patients provides rather high accuracy, 0.9. However, in those patients who present early, so those who present in the troponin blind period, it performs not as good, and here the new tests in color have clear added value and much higher diagnostic accuracy. So these are the tests for which you should hopefully currently use one of them in your clinical practice. And the editors of the New England journals agreed with our conclusion that the use of these high sensitive tests, of course in conjunction with the ECG, in conjunction with full clinical assessment, will improve the rule out and rule in of acute MI. Also important, of course, these findings have been confirmed by several other large multi-center studies, so this is really solid scientific evidence. It was solid enough so that already in the year 2011, the European Society of Cardiology guidelines clearly recommended the use of the sensitive or high sensitive assays and introduced 3 hours as the new time point when to do the second troponin measurement. So because the tests rise more rapidly, we can stop doing the second measurement after 6 hours and do it much earlier at 3 hours. And if at 3 hours the test is still normal, then patients, if they are pain-free, can be considered for discharge. If they have an if elevation already at the beginning, or if they rise within the 3 hours, and if all other assessment argues in favor for acute myocardial infarction, then patients should be considered for an invasive management. So the main advantage of the high sensitivity methods is that we detect small myocardial infarctions and we are much more rapid with our diagnosis. However, still 3 hours is a lot of time to wait, and it's important how to interpret these tests. The old troponin tests that were bad as assays, they were rather easy to use when they were positive, because when they were positive, they more or less always were associated with acute myocardial infarction. Now, with the good assays, the interpretation of troponin levels is slightly more difficult because we have identified that troponin is a quantitative marker of cardiomyocyte injury. Multiple conditions result in cardiomyocyte injury, and in fact, life itself in healthy persons like all of us in the room results in some form of cardiomyocyte injury. So with the best assays currently available, all of us in this room will have a measurable, a detectable troponin level. So it's important to differentiate a detectable troponin level from an elevated troponin level. So troponin can be measured in many patients who are healthy, in many patients who have chronic heart disease, and troponin levels are elevated with many forms of chronic heart disease, and the higher the level, the higher the likelihood that the patient does have an acute myocardial infarction. Therefore, if used as a diagnostic test, we should no longer use it as positive or negative, but use the absolute level provided, because very, very low level indicate a very high negative predictive value for acute MI, whereas very high level indicate a very high positive predictive values. If patients present with acute chest pain and only a mild elevation in troponin, then the differential diagnosis is very, very broad, and the positive predictive value therefore only 50%. So the concept now is to define what is the best troponin assay to use and to define algorithms that help to use it in clinical practice. So Maria Rubini Jimenez is a great research fellow originally from Valencia, and she's the first author in our paper of more than 2,000 patients in which we could directly compared the two best assays currently available. It's a high sensitive assay for troponin I and one for troponin T. And for us, for a clinical perspective, I think the take-home message is that both provide overall similar diagnostic accuracy. However, they have slight differences which might be of importance to know pathophysiologically. The I molecule seems to be better in early presenters, so the rise in troponin I seems to be slightly earlier. However, when what we do in clinical practice combine the presentation value with the later changes in troponin, the T molecule did have some advantages. And when it concerns the association with the risk of death, again, the T molecule did have some advantages. Overall, both are perfect tests, and overall, I think it's fair to say either one can be strongly recommended for clinical use. The future in the application of sensitive or high sensitive troponin assays will be assay-specific early algorithms. Of course, waiting 6 or 7 hours in the ED is passé. It's no longer necessary, and it's still currently, I think, unacceptable. Still waiting 3 or 4 hours is a long time period, and therefore a lot of research has been implemented how to achieve high accuracy at presentation, at 1 hour or at 2 hours. And one of the concepts is a 1 hour algorithm that has been established in the APACE cohort that kind of tries to put as many patients as possible either in the rule out or in the rule in pathway. Those patients who have a rather low level at presentation and no change in troponin within 1 hour can be assigned rule out. And this worked extremely well in the first data set. Those with a rather moderate to high level of troponin or with a substantial change within 1 hour, they can be assigned rule in and have a positive predictive value that is high enough to justify coronary angiography in all of these patients. 3/4 of patients by this approach can either be ruled out or ruled in very, very rapidly, and only 1/4 of the patients requires additional troponin measurement or other testing. This assay or this approach is now currently being validated in 2 external multi-center studies and seems to really provide a very high negative predictive value. Maria also is the key first author in another approach, a concept that was introduced in the UK by Rick Brodie to use very, very low concentration of troponin. So if the patient does have very, very low levels of troponin in the normal range at presentation, then this is associated with a very high negative predictive value. That was the case in the initial data set published in Czech and also in our data set. The only caveat I have with this approach is we should not use it in early presenters because here, at least in our data set, the negative predictive value was not high enough. However, in patients who present more than 3 hours from chest pain onset, it seems to be a very valuable approach. Then the only kind of other biomarker that I think you as clinicians should know about is copeptin. Copeptin is a completely unspecific marker. It really is released from the brain in situations of stress, endogenous stress. And the beauty of this marker is that it rises immediately at the onset of stress. So stress is highest at the onset of acute myocardial infarction. Therefore, in blue, you have levels of copeptin and green troponin. In those patients who present very, very early, copeptin levels already are very, very high. Whereas troponin is still low, troponin for the later presentations then rises and copeptin declines. Therefore, although in green you have the ROC curve for copeptin, so it's a poor marker, doesn't work well on its own, it's inferior to troponin, but because it has a complementary dynamic, it seems to be a perfect marker to be combined with troponin and to be combined for the use of the early rule out. That's a concept that has been now been studied extensively. More than 10,000 patients have been entered in well-conducted diagnostic studies worldwide. Mike Lipinski is the first author of a meta-analysis that has been just published 1 month ago, clearly indicating that in this 10,000 patient data set, there's an added value on top of troponin regarding sensitivity and negative predictive value by the use of copeptin. In addition, also just accepted for publication now in the European Heart Journal, for copeptin we now have a randomized controlled study in which 900 patients were randomly assigned to early discharge with the use of copeptin or management in a standard manner with the use of a second troponin measurement. And the findings are very convincing, so the procedure or the use of copeptin for early rule out is safe. The incidence of MACE is similar, and of course it's very effective. It allows us to earlier discharge patients. It reduces length of stay. The last point I'd like to highlight is that the use of the sensitive and high sensitivity assays have taught us important lessons about ACS pathophysiology. The ACS pathophysiology that we were taught includes plug rupture in these patients, includes thrombus formation and thrombus embolization as a hallmark of ACS. And I think it's fair to say that now this concept has to be challenged. And the data set that I think further helped to clearly challenge the concept, again, was derived from APACE. You have learned that troponin, high-sensitive troponin detects cardiomyocyte damage that was undetectable with the conventional assays. And now the key question we have asked ourselves is, do those patients who were considered unstable angina when using the less sensitive assays, do they have a similar pathophysiology on the myocardial level as patients with acute MI? So do they also show a small rise and fall? Of course, below the limit of detection for the old assays, but on the myocardial level, do they also have a rise and fall in their troponin as a kind of a hallmark for distal embolization, or are they silent on the myocardial level? So what we used for this is serial measurements of high sensitivity troponin. We've done this with 3 high sensitive assays just to see whether there's a change from the level at presentation to the level at 1 hour. So in those patients who do have non-cardiac chest pain, you see a Gaussian distribution with kind of all patients having either no changes or minimal decline or minimal increase just due to the analytical imprecision of the assay. That's that's the curve that indicates no change. No change within presentation and 1 hour. Patients who have an acute myocardial infarction do have a huge variety of changes from presentation to 1 hour, because the large infarcts will have a large increase, small infarcts a small increase, so that's a dynamic process. So what do you think would be the curve for patients adjudicated to have unstable angina? It looks identical to those with non-cardiac disease. So the vast majority of patients adjudicated to have unstable angina do not seem to have distal embolization as a pathophysiological hallmark of their disease. And I think this has huge implication. I'd like to highlight, I'll start with the 4th conclusion right now, because acute myocardial infarction, I think with the knowledge that we have now, must be considered a very different disease entity than unstable angina. Acute myocardial infarction does have 7 times the risk of dying. Acute myocardial infarction includes distal embolization. Unstable angina does not have distal embolization. And I think that's the reason why we have learned from our clinical trials that patients with acute myocardial infarction benefit from aggressive antiplatelet therapy, while patients with unstable angina do not. No benefit in plateau. Patients with acute MI benefit from early revascularization, learned from tactics. Patients with unstable angina do not. So the better terminology, the better phenotyping we can do with the new assays is extremely important, because it helps to understand that the pathophysiology is different, and therefore I think the term ACS, although it is used in the headline of this session, I think should be reconsidered. ACS includes 2 very different diseases, and in order to get the best patient treatment, we should differentiate them. Regarding biomarkers, you need a sensitive or high sensitive troponin assays. Those that are on the market are great tools. You need to learn and teach your colleagues how to use them. They need to be interpreted as quantitative markers of cardiomyocyte injury. And very soon, I think we will have strong enough data to apply clinically one of these early algorithms, either with or without the use of copeptin. I thank you for your attention.
Thank you, Dr. Müller. I would like to ask about a point you raised on the time to presentation. So it's very important, and the predictive value of any test depends on this point. And you showed that high sensitive troponin T could be used to rule out patients at the detection limit, using the detection limit, not just the elevation limit, provided that the presentation time was longer than 3 hours. My question is, if we could use copeptin during the first 3 hours, and then from 3 to 6, the detection limit of the troponin T, high sensitive one.
Yeah, so I fully agree with you. I think that's the concept that would make most sense at the present time. So the high sensitive tests are great, but still, if patients present very early from symptom onset, I think we need to be cautious because still, if the patient is healthy before the onset of acute myocardial infarction, if he's a young patient, he or she will need some time until the levels rise, and therefore copeptin might really be perfect for these patients who present very, very, very early. For patients who present, let's say, after or more than 3 hours from chest pain onset, I think all of these early algorithms will be safe to use.
Is there any question from the audience? Yeah.
Thank you, Christian. That was a nice presentation. I wanted to ask you about your last conclusion. And it's pretty clear that once we have high sensitivity troponins, we can make a bigger differentiation between myocardial infarction and stable angina patients. But I'm not sure whether you're very strong in your conclusion that it is a really separate disease. I think we have the experience of patients who really present with ECG changes. You go to coronary angio, you have a severe lesion, or even you can see thrombus in the coronary artery. That's clearly my problem with unstable angina, and I think those that we've been doing registries for many years, is that actually you have a pool of patients with very different presentations. You have young women with normal coronary artery diseases, some other chest pains that you don't have explanation, and then you call it unstable angina. And I agree with you that clearly that pool of patients, which is very heterogeneous, makes a difference. Clearly, because, but I'm not sure whether you have really unstable angina in which you have coronary artery disease, severe coronary artery disease, really makes such a difference with those with unstable angina. My question is whether it is just this dilution of these different clinical scenarios than that of those who are really coronary artery disease driven.
So Hector, I'm very thankful for your comment. I think you're absolutely right. Looking at registry data, the unstable angina group for sure included all of the, or may have included some of the entities that you have indicated. For the purpose of the diagnostic studies that I referred to, unstable angina was adjudicated by 2 independent cardiologists using coronary angiography data, clinical presentation, ECG findings, and all the stuff that we have available. So these are patients who really did have chest pain at rest, at least for a short period, that was considered related to significant coronary artery disease. So I think the dilution aspect should not be a major problem. But I fully agree with you that still unstable angina can be a patient with substantial ST segment depression that of course does have severe coronary artery disease. I'm not saying unstable angina is not coronary artery disease. I just think it's a different phenotype of coronary artery disease that seems to benefit from different forms of therapy. I think the antiplatelet approach makes only sense if there's thrombus. If it's a high-grade lesion, the patient may still, of course, require cardiac surgery, but he may not have the same benefit from aggressive anticoagulation or antiplatelet if there's no thromboembolic lesion involved. So I just think the data is very, very convincing that, of course, with the caveats that you mentioned, to take the clinical trial findings that we have, that the benefit already is different from the treatments for early revascularization and for antiplatelets, to be more specific in our clinical terminology, either calling a patient myocardial infarction or unstable angina.
Well, thank you very much, Dr. Murlo. And we have to move to the next presenter. And that's Dr. Malcolm Bell. Dr. Malcolm Bell is from the Mayo Clinic, is a cardiological interventionist, well known from us, and it's also a friend. I don't know how many times you came here in Spain, but many of them. And it's a great football player, and so it's my pleasure to present Dr. Malcolm Bell.
Thank you very much, dear chairpersons, for the very kind introduction. You know, for the last several years, I've been privileged to have been invited to speak at this meeting every 2 years. And as I said, that's been a great privilege. However, to renew acquaintances with just wonderful friends and colleagues, that is priceless. And I'd like to just thank and congratulate the organizers of this meeting for their continued success of what is really an excellent meeting. So this is a rather broad topic I was given here, and I anguished about how to present this, and obviously I was free to discuss anything here, difficult management decisions in ACS. And so what I've chosen to do today is to present this as a case-based approach, and I'm going to present 3 clinical scenarios. And I hope for those of you who are predominantly in clinical practice, you will find these of educational value. It's unfortunate, but I do not have anything to disclose financially. I'm going to start off with a case of heparin-induced thrombocytopenia as the first case. And these are real cases. This is a 75-year-old gentleman that we were looking after last year with a history of diabetes, no recent illness, no recent hospitalization. And he presented with a non-STEMI on a Saturday evening, and he had the typical presentation with chest pain, some ST depression on his electrocardiogram, and a positive troponin. His pain settled down. He was initially treated, as you can see here, with unfractionated heparin, clopidogrel, a beta blocker, and a statin, what we would consider to be fairly standard treatment at our institution, and I suspect yours as well. And as I said, he had presented on the Saturday evening, and the angiogram was scheduled for Monday morning, and he remained pain-free during this period. Just before he went to the cath lab, it was noted that his platelet count had fallen from 160 to 98. So the question I have for you is just to think of just answer this yourself. Is this heparin-induced thrombocytopenia? What should we do with this? Well, in this particular case, we decided not to do anything. We continued the unfractionated heparin, and the patient went to coronary angiography and had an uncomplicated PCI and had no further events. And just to emphasize this, and the reason why I've chosen heparin-induced thrombocytopenia is because at least at our institution, it's interesting that many of my colleagues are still a little confused about how to approach this and how to diagnose this. And this particular example that I have given you here is a typical example of, it is heparin-induced thrombocytopenia, but it's the non-immune type, the type 1. And this is actually not uncommon. We see this with heparin in the first day or so in many patients. It's a mild fall in the platelet count, but it quickly returns to normal. It's totally benign. It doesn't require any specific treatment. We don't have to go and stop the heparin in such a case. And so this is one group of patients that, again, as I said, at our institution, we continue to see some confusion about this and how to manage it. Now, in contrast, let me show you another case. And this is a patient just a few months ago, a 68-year-old female. And she had been in another hospital for 48 hours with a non-STEMI, and she was also treated with unfractionated heparin over those 48 hours. As you can see, she had a history of diabetes, and she had chronic kidney disease, stage 3B. She was transferred to our institution for an angiogram and possible PCI. The unfractionated heparin was continued. We started her on clopidogrel when she arrived. And you can see here that she has a normal platelet count, but her creatinine is significantly elevated. Because her creatinine was up so high, there was some reluctance, particularly on the part of the patient, to proceed with angiography. She had been terrified of having to undergo dialysis, and so she did not consent to an angiogram, and so she was observed for a few more days and continued on the heparin. On day 5, though, she had recurrent chest pain with some ECG changes, and it was noted that her platelet count was 138. So this is a significant reduction compared to the 300 I showed you from a few days before. So now the question is what to do. She's had no further pain since a few hours before, but this is a concern that she's had recurrent pain and her platelet count has dropped. She had the ELISA antibody test of the platelet factor 4 heparin complex, but of course this takes some time to get the result of this. So now just ask yourself how you would approach such a patient. And this is quite clearly very suspicious of the type 2 heparin-induced thrombocytopenia, and really the only one we need to be concerned about. This is the immune type. And the importance here is it's quite frequent, maybe up to 5% in our hospitalized patients. And it is a serious condition. So this is something that you're going to see frequently. And maybe just a quick show of hands of people who are working in hospital practice. How many have seen a case of heparin-induced thrombocytopenia in the last 12 months? A quick show of hands. So it's a significant number of you indicating that you've looked after these patients. And just to remind you, this is really a clinical diagnosis, and the so-called 4 Ts, looking for thrombocytopenia with at least a 50% drop in the prior count. It doesn't even really have to be abnormal. The timing is important here, and the immune versus the non-immune type, this is really where the differentiation occurs. The classical time is between 5 and 10 days, as was illustrated in the second case I showed. In contrast, the first case was in the first 36 hours or so. That's too early for the immune type of heparin-induced thrombocytopenia. On the other hand, it can occur very quickly, in under 5 days, sometimes within a day, if the patient has been exposed to heparin within the last 3 months. So that's something just to keep in mind. We should also think of other causes of thrombocytopenia, such as some of the drugs that we give our patients. And the other thing to look out for is thrombosis. And as you know, this is more typically a venous thrombosis rather than arterial. But in that second case, remember, she had recurrent chest pain in the middle of the night. This was recurrent myocardial infarction, so this was arterial thrombosis. So this was a classic case of the immune type of heparin-induced thrombocytopenia. And then really the educational value of this, showing this case, is how to approach this. There really shouldn't be any delay. This can be a life-threatening condition. People can have amputations, strokes, and can die. It's critical that all heparin is stopped, including low molecular weight heparin. We do not switch from unfractionated heparin to low molecular weight heparin. We should look for thrombosis. Current guidelines would tell us that we should be doing ultrasounds, looking for DVTs. There's some, I think, inconsistency in how that's approached. The most important thing, though, is making sure that you're thinking about the diagnosis. Again, as I said, looking at the antibody, that's going to take some time, and we shouldn't wait for the result of that. We've still got to treat the patient immediately. And so even if there is no thrombosis present or evident to you, it's critical that you start a direct thrombin inhibitor. And argatroban is the drug of choice here. It's its approved indication. Many interventional cardiologists are very comfortable using bivalirudin in the cath lab and think that this can be used for patients with HIT when they're outside of the cath lab. And that may or may not be reasonable. But be aware that bivalirudin for this indication is off-label, other than for during PCI, and it is more expensive than argatroban, at least in the United States. And lepirudin was around for some time, but this is now no longer available. So with that in mind, I'm going to move to a second clinical scenario, and this is something which I think we all find very perplexing, and that is the patient who is receiving oral anticoagulants who presents with ACS. And again, I would like to illustrate this by showing this case. And this is a 75-year-old gentleman who again presented with a non-STEMI. He had a long history of chronic atrial fibrillation for which he was anticoagulated with warfarin. He had a CHADS-2 score of 3, and a week or so ago before he presented, his INR was 3.1, and he had had quite a stable INR in the outpatient practice. So then the question we ask ourselves is, what should we do with this patient? And we'll just illustrate this case. We're just focusing on 3 issues. The first is, if we're going to do an angiogram, what vascular access are we going to use? Are we going to stop the INR? Are we stop the warfarin? Are we going to reverse the warfarin? What about dual antiplatelet therapy in a patient who's on oral anticoagulants? And what about our choice of stent? And I think it's fair to say that this is an unresolved dilemma, and I think that I've spent most of my time discussing this morning. But as we think about this, this is clearly a balance between the risk of stroke on one hand versus the risk of stent thrombosis on the other. But I'd like you to think about it more than just that. We should also be thinking of mortality. And this often gets lost as we discuss this. We're talking about the risk, as I said, of stroke versus stent thrombosis. There's a risk of bleeding, which I'll come to in a moment. But mortality is something that we often forget in these patients. So this is a complex area. Of course, we're now talking about whether to offer the patient triple anticoagulant antiplatelet therapy. So on this slide, what I tried to summarize is what we think we know about this. Well, clearly from many retrospective studies, and particularly I think we're indebted to the Danes in Denmark, that they've analyzed this a lot from their national registries. But the bleeding risk compared to warfarin alone, if you have triple therapy, is 4 times higher. This is a major bleeding. And the number needed to harm is only 13. So this is a real risk to the patient. And the important thing to recognize here is the risk is immediate. It's not something that's just going to build up over time. It does. But the risk is immediate. So you have to make that decision about treatment right from day one. It's not something that you can readdress in 1 or 2 months' time. And the majority of elderly patients make this actually even more complicated for us, because most of these have an elevated CHADS-2 score. And as I'll discuss later, many of these patients are also at higher risk of bleeding. So these are very challenging patients to deal with. But here's something which even I've only just really come to sort of appreciate in the last year or so, is that adding aspirin to warfarin in patients who have stable coronary artery disease provides no additional benefit. It doesn't decrease the risk of ischemic complications. All it does is increase the risk of bleeding. And I'm not sure what the practice is in Spain or other parts of Europe, but certainly in the United States it's been very common to add a little bit of aspirin to patients receiving warfarin if they have coronary artery disease. But we really don't have a lot of data to support that notion. And in fact, again, from the Danish registry, just recently published this year, clearly showed that there was no incremental benefit. So I think we need to challenge ourselves in that question about whether or not to give aspirin to these patients. And this has also been shown in patients who've had an MI or who've undergone PCI, and we'll more on that in a moment. As we think about triple therapy, we're really talking about aspirin, clopidogrel, and warfarin. But of course, we're using drugs such as ticagrelor and prasugrel, and what we know about those agents is that they increase the risk of bleeding over clopidogrel, particularly prasugrel. So we have to be very careful about using these agents in people who are on oral anticoagulants. I can tell you in our own practice, we avoid these agents even though we prefer to use ticagrelor for ACS, but not in patients who are on oral anticoagulants. And then finally, the use of novel oral anticoagulants is rapidly increasing. And what do we know about those? Well, we know that they decrease the risk of stroke, They improve survival over, compared to warfarin. I'm talking about just the atrial fibrillation and the DVT patients, but particularly atrial fibrillation. But in particular, they decrease the risk of intracranial hemorrhage. So this is a group of patients and using these agents that we're going to have to get more comfortable with, and we're going to have to address this as we see these used more frequently, although of course their price is really a barrier to universal implementation. So what are we learning? Well, in terms of oral anticoagulants, the benefit is the decrease in mortality, and this outweighs the risk of bleeding. This has been well documented in many trials, and we see this in our own clinical practice, that patients who should be on warfarin are not given warfarin because of this concern about the risk of bleeding. And yet, most of these patients are at high risk of bleeding, but that risk is dwarfed by the decrease in mortality. So there are many more of these patients should be on oral anticoagulants. And to my knowledge, the only randomized trial that has addressed this in terms of the ACS, PCI population is the so-called WOAST trial. I'm not going to show you slides on this, but just to remind you, this was a comparison of aspirin, clopidogrel, and warfarin versus warfarin and clopidogrel alone. And although the trial may have been a little underpowered, it's the only one we've got. It was still a well-conducted trial, and it did show that the combination of oral anticoagulants and clopidogrel was safer than triple therapy and was not associated with an increased risk of ischemic complications. And importantly, again, as I emphasized, not withholding warfarin, because otherwise we're exposing our patients to the increased risk of stroke. And in fact, I would also tell you, again, from the Danish registry, has also shown this in a very large retrospective analysis, showing that the safest combination in patients who had MI or PCI was the combination of warfarin and clopidogrel. Again, aspirin did not add anything to that, and the mortality. Again, we're not talking about stroke, we're not talking about bleeding, we're not talking about stent thrombosis, we're talking about mortality was lowest in the patients who were receiving warfarin and clopidogrel after PCI or MI. Just less than half a minute on the transradial approach. I don't think there's any question here that this is the approach that we would favor in patients who are anticoagulated. I can tell you that in our own practice, as long as the patient is suitable for a transradial approach, which most patients are, we actually do not stop the warfarin. We do not wait for the INR to become normal. We actually go ahead and do the procedure without stopping the anticoagulants. And then finally, and this may be something that is perhaps a little controversial, and as we give lectures there, we have to remember that sometimes there's only one or two things that the audience is actually going to remember. And if there's one thing you remember today, it's what I'm going to tell you now. I think for too long now we have been told that in these patients, or anyone who's at risk of bleeding, that we should be providing bare metal stents rather than drug-eluting stents. And I think this is where, it's a good example, I think the guidelines are way out of date on this. And in fact, in the last year or so, I think many of you have probably seen the literature that current analyses of the second generation stents. So we're not talking about the Cypher stent or the Texas stent, but indeed the newer generation stents are actually safer than bare metal stents with a decreased risk of stent thrombosis. And this has also been seen in a recent, and as we're talking about ACS, this has also been seen or demonstrated in a recent network analysis of primary PCI patients, where clearly the risk of stent thrombosis was less with the second generation stents than bare metal stents. And of course, we're now experimenting with shorter durations of dual antiplatelet therapy. Is it 6 weeks? Is it 3 months? Is it 6 months? I think we're going to see the results of many trials in the very near future, and I think you can see that things are moving towards a shorter duration, which obviously would favor these patients who are on oral anticoagulants. So recommendations for now would be that, yes, we should assess their stroke and their bleeding risk, but the CHADS-2 score is probably more important than a bleeding score because, again, when we look at the data for these patients, most of these patients do have a higher bleeding score, such as the HAS-BLED score, but they also have an elevated CHADS-2 score. And again, just emphasizing, we're trying to reduce mortality. And so the CHADS-2 score is more important, and so we should, in most patients, should not be withholding oral anticoagulants. I emphasized using the transradial approach and considering the use of second-generation drug-eluting stents. In our own practice, again, this is the only trial we have, is the WOAS trial, and we've actually started to implement this very carefully in selected patients, and so far this does not seem to be a problem. And as I said, the Danish registry, I think, would support this in a large retrospective analysis. The duration of this therapy, of dual antiplatelet therapy, at the moment, I think we're just not sure. And I think this has still got to be individualized for the patient, how many stents, length of stent, diabetic, size of vessel, etc. These patients are at increased risk of bleeding, and GI bleeding is the #1 cause of bleeding here. We do still give proton pump inhibitors. Again, probably no major problem with that, but we now sort of just avoid using omeprazole and esomeprazole because we have other PPIs that we can use. And this, of course, is because of the CYP2C19 issue here. And then I think we need to await more safety data with the use of novel oral anticoagulants. These have been tested in the ACS population, but I think for these patients who need oral anticoagulants, I think we still have a lot more information to gather, but it's going to be an important area. If you're interested in reading some more in-depth discussion of this very detailed analysis, Dominic Angelillo, who's speaking at this meeting, just published this recently, and I would refer you to this. It's a very good document there. We have other patients who have mechanical prosthetic valves, patients with a history of venous thromboembolism. These are also patients that we need to deal with when they present with ACS. These may be different patients, though, because the AF patients tend to be a little bit older. Some of these patients tend to be a little younger. Again, I think we need to individualize our approach. And then finally, and I'll just do this very quickly. This is a case of a 90-year-old patient presented as an emergency with a non-STEMI, a patient with advanced chronic kidney disease, as I said, 90 here with a GFR of 18, very high GRACE score. The question is, do we proceed with an invasive approach here? And at least in our practice, this is a common problem. We have a lot of elderly patients, many of them with advanced chronic kidney disease. And just to remind you that we're talking about really stage 4, stage 5 chronic kidney disease. And just to emphasize, the outcome of these patients is terrible, absolutely terrible. With an invasive approach, about half of these patients are dead within 1 year. Very high mortality. And so when we think about dialysis, in our own practice, I like to think about this sometimes, perhaps unfortunately, but the misery of hemodialysis. And particularly, the very poor quality of life, particularly if these patients have coronary artery disease, and the elderly. They have very high mortality. The average life expectancy of a patient in their 70s on dialysis is 3 years. If patients over the age of 80, they have a 60% 1-year mortality. And that's with or without coronary artery disease. But the unfortunate thing here is many of these patients lack the decision-making capacity at the time of withdrawal. There's a lot of patients who have dialysis withdrawn. And many of these patients, we have to deal with end-of-life issues, but many of these patients have regrets. 50% of patients who are elderly on dialysis state that they wish they had never started dialysis. Another 50% say they only started dialysis because that's what their physician wanted. At least that's their interpretation. And so as I finish here, I think we need to think about this concept of shared decision-making in such patients. And this is more than just providing informed consent. This is taking into account the patient's values, their preferences. Do we ever start a discussion with the patient before we provide any information and ask them, the patient, are you the one that's going to make the decision? Do you want me to make the decision? Or some combination of that? And that's something we should be thinking about. We provide them data. But you know, in the United States, I think it's about almost 50% of adults in the United States cannot calculate accurately a tip on a restaurant bill. So even to assume that they have literary skills and then to think that they have numeracy skills is a big assumption. And 20% of college-educated adults in the United States can't tell you whether 1% is less than 2% or 5% when we're talking about risks. So I think these are big challenges for us, and particularly for these types of patients. So I think we need to think about ways of incorporating this into our clinical practice. So I'm going to stop there. If you have any questions that come up afterwards, here's my email address, and feel free to contact me. Again, thank you for the opportunity to be here, and thank you for your attention.
Talk is open for questions. Dr. Sionis?
Well, it was a wonderful clinical talk, facing some of the problems we see every day in our clinical practice. So I was wondering, what did you finally do with your 90-year-old patient? Did you send him to the cath lab or not? Because one thing that I find with this patient is that if you, of course I have a very high mortality risk, and if you don't do, if you treat them conservatively, then they end up coming back to the emergency room, and then probably they face even a higher risk in the end, and you end up maybe doing an angiography with them after a week.
You're absolutely right, and that's why these are so challenging, and I don't pretend to have the answers for this. That particular patient was a very vibrant, gentleman, strong patient. I thought he would agree to have an angiogram. He did not. But he did have recurrent chest pain, just as you would predict, but each time it was managed with some more anti-anginals, and this was quite a few months or so ago. About a month ago, I was actually just checking on him when I was preparing this talk, and he's actually been pain-free since then. Fortunately, he had normal left ventricular ejection fraction. But I quite agree with you, another such patient may well have had some problems. And in fact, I could have shown you another case of a 92-year-old woman who I looked after in December with a STEMI. And again, the same question came up. She had even worse renal function than that gentleman, had never been on dialysis. But she ended up having primary PCI. She went into acute renal failure. She remains on dialysis. And she's been back in the hospital now 4 times with recurrent heart failure and fluid retention. So it can be, there can be problems either way. These are such difficult patients, and I wish I knew the best way to manage these. I think the important thing, as I emphasized here, it's really important to make sure the patient really understands and they really are part of the decision making, and particularly the family. It's a very difficult group of patients.
Dr. Miller?
So I'm very thankful that you highlighted these very challenging settings. May I challenge you on one of your recommendations and thoughts where I slightly respectfully disagree? Why are you withholding the treatment option that, if anything, has been clearly shown to reduce the risk of intracranial bleeding? in those patients where we kind of struggle with the overall high bleeding risk among the triple therapy option. I think it's the most consistent finding or benefit of the NOACs very likely is the reduced intracranial bleeding. Why are you not coming to a different conclusion?
So a great point, and I wish we had a whole lecture on this. I'm not actually recommending against their use, and in fact at the moment recognizing that this would potentially be off-label, and I think it would be important for us to avoid, again, prasugrel and ticagrelor with these agents. But I agree with you 100%, Kristen, because we have these, we're seeing this more and more, and at the moment we're actually putting together a task force to make some recommendations for this, but recognize we just don't have a lot of support for this in the literature. And the only studies, which I didn't have time to present here, and I hope people appreciate the fact that I wasn't showing many trials here and showing survival curves. This is more clinical. But we know from the APPRAISE-2 and the ATLAS-2 trial where these agents were used in ACS patients, there was an increased risk of bleeding. And as I think it was in the APPRAISE one with apixaban, there was an increased risk of intracranial hemorrhage. So we have to be a little careful. We just don't have enough data. So I guess all I'm saying is I'm just trying to be a little careful and not go beyond the data. But I quite agree with you. I think there's a future in those agents in these patients. On the other hand, they're of no value in the patients with mechanical prosthetic valves and shouldn't be used there. But I agree. And the big barrier we have, as I said, is expense. These agents are incredibly expensive. But if I had atrial fibrillation, God forbid, I would want to be one of the NOACs.
Last question, Dr. Barrabés.
Thank you, Malcolm, for an excellent presentation. I only have a small point regarding the BOST strategy. Don't you think that it's a bit premature to just recommend this strategy for the majority of patients with non-valvular atrial fibrillation, given that the BOST trial was quite a small trial? Part of the patients had other indications for anticoagulation, needed higher INRs, and the incidence of bleeding was quite larger than in other trials or registries of patients with non-valvular atrial fibrillation. And we know that dual antiplatelet therapy has been the standard protective therapy after a stent.
Sure, and hopefully I made that point that it is potentially underpowered. Most of the bleeding was considered to be minor bleeding. On the other hand, it is the only trial we have. And as I said, when we look at, you go back a decade, look at the Walrus trial. There was no additional benefit of aspirin with warfarin in MI patients. So recognizing that, the data from Morten Lambert's from Denmark, again, clearly showing that the best outcome was in the patients who were not treated with aspirin. So we've thrown that all together, and recognizing that patients have a 4 or 5 times risk of major bleeding, we just feel that we have to try to do something. It's a bit like the question about the NOACs. We've taken that step. It hasn't been endorsed by all of my colleagues, and some people will say, well, give them aspirin for 4 to 6 weeks. But that's never been tested, and as I emphasized, the risk is immediate. So I take your point. These are our recommendations. I think it's something we all have to think about.
Thank you very much. And the last talk will be done by Dr. Robert Klaus, professor at Leiden University Medical Center and head of thorax surgery department. He is a cardiovascular surgeon. He is well known to be specialized in difficult situations, in special for his contribution in mitral regurgitation repair and ischemic mitral more specifically. His talk this morning is recurrent angina after CABG, a clinical dilemma. Thank you for him.
Well, thank you, chairs, and I would like to thank the working group of the Spanish Society for inviting me to present this lecture and also present this today and not tomorrow, where it actually was originally planned, but tomorrow I have to go to Portugal to talk to the Portuguese Society of Cardiac Surgery on the future of cardiac surgery And in this area of PCI and TAVI, you can imagine that's going to be a challenging talk, so I need some time to do that. But this is, initially I thought, well, angina after CABG is an easy talk. It's the most researched and published operation in the world literature, and there must be some interesting information there on the, in fact, the failure of CABG. But as we're thinking about failure of bypass surgery, it's not a topic we like to discuss as surgeons because we think that this is the ultimate treatment for angina. But I'll share with you that it's a difficult problem, and it's indeed a clinical dilemma. So where are we currently with isolated bypass surgery? And to see where we are and how we progressed in this field of surgery, we usually refer to the SDS database, which has millions of operations in there, and in the last decade there were 1.5 million isolated primary bypass surgeries in that database. And if we look how they perform actually pretty well. This is the predicted mortality, which is stable over that decade, but you can see that the observed and adjusted mortality is decreasing over the years to a level that's below 2% right now. So there is an advancement in the outcome of bypass surgery. And also a bad problem was stroke rate is decreasing. This is the predicted stroke rate, which is stable over the years, and the predicted and observed stroke rate is actually decreasing over the years. So there has been a lot of advancement in PCI, but also in bypass surgery. It's not just the surgery, it's also anesthesia, the whole management of these patients, using off-pump techniques, etc., etc. So if we talk about recurrent angina, I wanted to discuss 4 topics. The incidence of the problem, both in short and long term, how we diagnose this, how do we treat the recurrence of angina, and probably most important, how we prevent angina after bypass surgery. So what about the incidence? Well, it's, what are we talking about? Are we talking about restenosis or progression of the native disease? That's the underlying pathology. Or do we measure repeat revascularization, which is a very easy thing to measure, but it's only the tip of the iceberg, because once people get angina, then only when there is very difficult to manage, they get into a repeat revascularization situation. But angina is difficult to assess. It's influenced by medication, by the self-medication, whether they take it or not, or maybe they had some drugs before the operation. It's also influenced by the fear for reintervention. Many patients that have undergone a surgery, they know if they go back to their cardiologist and say they still have a problem, that there might be a chance they have to go to a reoperation and don't like that at all. So the assessment of angina is not easy after bypass surgery. We do have some information from the Syntax trial. You can remember 1,800 patients with 3-vessel disease randomized to PCI and CABG. Unfortunately, there was also a sub-study that used the Seattle Angina Questionnaire and some other forms of general health status questionnaires, and they interestingly associated this with the repeat revascularization strategies in these patients. But first, let's look at the incidence of angina in these trials. This is from the paper by Cohen, published in 2009 New England Journal. And you can see that on the angina-free frequency score, they score 94, which is pretty good. At 12 months, they have 60% had substantial improvement, but only 76% was angina-free. So although CABG is probably the most effective and most cost-effective therapy for angina, it's not a perfect therapy. 76% angina-free, I was a bit shocked by that number. I would suggest that it was close to 90%. Well, it's not. And to make it even more complex, there is a relationship with the recurrence of angina and the reintervention rate. Obviously, patients with repeat revascularization had more frequent angina in the Syntax trial. That makes a lot of sense, okay. But there was a difference in the need for repeat revascularization, and that did not completely explain the benefit of CABG over PCI. There was a difference between these two groups. And the need for repeat revascularization was associated with a larger reduction in angina after CABG than after PCI. So it seems that some of the anti-anginal effect of cabbage may result from mechanisms unrelated to the relief of myocardial ischemia. This is something that we have to think about in the future and also in the design of future trials. What about the incidence in the STS database? This is information from a patient cohort that underwent cabbage over the age of 65 years, so it's the older population. Primary cabbage, 700,000 patients, and they were followed up for 18 years, and then the data was linked to the Medicare data. And although the percent of recabbage is very low, there's a tenfold incidence of repeat revascularization, and that's probably only, that's mainly PCI, obviously. And the risk factors for repeat revascularization, that's very obvious, that are these guys. And negative risk factors are advanced age, left main disease, and smoking, because they probably die from these conditions. Well, I can be very short about the diagnosis of angina. It's not very different than in regular patients with primary angina, and I don't have to explain in a cardiology meeting how to diagnose angina and how to follow up these patients. But there are some special aspects which I would like to draw your attention to, and they are very important when we go into these heart team discussions, when we discuss how we're going to revascularize these patients. First, it's important that all the grafts are visualized, including the use of the GAA. It's not a very common bypass artery, but it's very difficult to visualize. You have to go into the celiac trunk and be a very good interventional cardiologist to find that artery, but it's usually, in most patients you can find it. We have a practice where we do use the GA quite a lot, and and our cardiologists are usually able to visualize that vessel. I think a CT scan is important to assess not only the epicardial grafts and vessels, but also to assess the risk of re-entering that chest. It's a big difference whether there is a memory artery or a venous graft crossing the sternum, or is it not, if you want to decide how you're going to revascularize that patient. A previous op report is important. You want to know where all the grafts are. And a very interesting problem is the subclavian artery stenosis. We all know about it, but there are many instances where it's overlooked, especially when you come from the groin or from the right artery, that the right radial, but if you have a left subclavian artery stenosis, it can be very difficult to think about it. It's easy to diagnose, but you have to think about it. This is some interesting pictures published a few years ago on a patient that had a refractory angina after bypass surgery, and this was the left coronary angiogram, and there was obviously a stenosis in the subclavian artery, and you can see a shadow of an IMA graft right there, and after a stent in the subclavian artery there was a beautiful IMA, and the patient was resolved and relieved from his angina with just one stent. It becomes a little bit more difficult how we're going to treat these patients. Well, initially it's obvious that they need medication, but after they fail their medication, we have to consider an intervention. And I'm not going to go into the details of interventions, you probably know all this, but there are a few things that are interesting, and this is not only the benefit of FFR-guided PCI for native vessels, but also for stenosed grafts. You can see this was published last year in the American Heart Journal. This is the MACE-free survival of patients that had a FFR-guided PCI of a graft versus an angio-guided stenosis, and they do much better if we do FFR-guided PCI. And this is corrected data, and this is corrected data. And even a total occlusion of a graft can successfully be treated by PCI. The success rate is maybe not as good as with a native vessel, but a graft can be occluded. And once it's successful, the angina improvement is very good in that group. It was only a small study, but still a 90% success rate. And at last follow-up, 80% of these patients were angina-free. So a PCI should really be the first line of intervention for these patients, but it doesn't always work very well. There is a higher restenosis rate than in native vessels. and therefore we still have to consider to do a redo CABG. Has a bad name because it's used to be a very high-risk procedure, and it's also being performed less frequently. This is from a Canadian experience, very large center in Toronto, where the percentage of redo CABG was depicted here in several age time frames, and you can see that the percentage of redo CABG has dropped to about 2% in that center. In my own center, it's about 3%. So indeed, we're doing less redo CABGs than we used to do. And there is an increase in patients that had a previous PCI before they got into the redo CABG. The outcome, however, is still pretty good. This is the overall mortality hasn't increased, although we're operating on more complex patients, older patients, and the low cardiac output syndrome is a less frequent problem after these types of surgeries. We have basically learned how to do these operations much safer. We have learned that off-pump strategies are probably better in the redo setting than on-pump setting. It's on-pump operation. In primary CABG, it's hard to prove the difference. It's probably there to prevent stroke, so in elderly patients. But in the redo setting, it seems to be a better option. And this interesting study where they had 600 patients, of which 70% had off-pump procedures, they did propensity matching, so they got two groups of 200 patients that were comparable in baseline characteristics and number of distal anastomosis. And then when you compare the two groups, they had better outcomes in all these endpoints. Both the 30-day mortality was about half, composite endpoint of mortality and major morbidity, prolonged ventilation, ICU stay, and blood transfusion were all better in the off-pump group. So if anywhere the off-pump procedures have a benefit, it's probably more in the redo setting than in the primary setting. It's more complicated, but it probably benefits the patients. And what about the long-term benefit of a redo bypass operation? This is an experience in a small center. It's only 100 patients, single center experience. 30-day mortality was low, but the freedom from cardiac symptoms was remarkably good at 1, 5, and 8 years, being 90, 84, and 68%. But I think the most important aspect of the recurrence of angina is the challenge that at the primary operation, we conduct the operation and we give these patients medications that prevent angina in the future. This is the important role of lipid-lowering medication after bypass surgery. This is a trial that was designed to study on versus on-pump surgery, the RUBY trial. This was just a sub-study, where patients were divided into groups that had lipid-lowering medication at discharge and did not have lipid-lowering medication on discharge. And look at the change in mortality, which was significant, almost 2% and 5.4%. So this sub-study showed that that's an important part of the secondary prevention after bypass surgery. Other very interesting information is from these huge trials, the Triton TIMI38 trial and the Plato trial, which studied prasugrel and ticagrelor. And if you go to the CABG subset, which was only, we think it's a big number, but it was only a small number of patients, with only 3.6% of the entire population. But these patients went on to bypass surgery somewhere in the inclusion period of the trial. And when we compare then the mortality rate on patients on prasugrel and clopidogrel, look at this difference in this bypass surgery group. This is the 1-year mortality on clopidogrel and this on prasugrel. That's a big change. So probably either because it does something on secondary prevention or it has a role in the whole setting of PCI and acute coronary syndromes, these patients after bypass surgery seem to do much better if they're on prasugrel than on clopidogrel. And you may say, well, that's due to the fact that prasugrel is not such a good number, but even with ticagrelor, there were 2,000 patients in the Plato study who underwent CABG. This was an ACS trial, not a PCI trial. But the same difference, it's a less different, but it was a significant difference in mortality 1-year mortality between the patients that were on clopidogrel and on ticagrelor. So there is a lot of medication that can prevent recurrent angina after bypass surgery. That's for the cardiologists. But what about the surgeons? Can they do a better job? I think they can do a better job because there are two aspects that are very critical in the outcome, the final outcome after bypass surgery. First is complete revascularization. This is data that was gathered by Garcia last year, published in the JACC on 35 randomized controlled trials, 90,000 patients, and about 50% in these trials had complete revascularizations on either PCR or CABG. It was pooled data on interventions. Now, if you compare the results of complete revascularized patients with incomplete revascularized patients, complete revascularization reduces long-term mortality. It reduces the risk of myocardial infarction, and it reduces the risk of repeat revascularization. So although it's a very old dogma that we have to do complete revascularization, there's more and more data that supports it, and this is probably the most solid data I could find. Second thing, besides complete revascularization, is the use of arterial grafting. And this is data from the Cleveland Clinic, probably the largest clinic for bypass surgery. They have data on 50,000 patients, 4,000 re-interventions followed up for 25 years, published by Sebik, who's now the director of the Cleveland Clinic Cardiac Surgical Division. Published a few years ago, but it's still very strong data. They did some modeling, and this is the freedom from re-intervention on this axis, and this is the years after operation. This is 20-year follow-up of the different types of graft we're using. This is without any arterial graft, only venous grafts. Big difference if we use an IMA graft, one IMA graft, but the same big difference if we use two IMA grafts. It's not just the lima we need to use two grafts. Same group of patients was published a year later on the angiographic outcome of these grafts. And this is the rough data on the patency rate of ITA grafts up to 16 years, venous grafts up to 16 years. If we model that, this is how the picture looks. And it's not only that it's a benefit to the LAD. This is a bit of a complicated picture where they modeled the difference between a venous and arterial graft on the different system. And this is when an arterial graft has an advantage. And it's both on the LAD, diagonal, circumflex, and PDA artery that there is a benefit over the entire range of stenosis. It's only the right coronary artery where there's a low grade of stenosis that maybe a venous graft may be better than an arterial graft. This is for the LAD, difference between ITA and venous graft. This is a difference to the diagonal, circumflex, and PDA branches, difference between ITA and venous graft. And it's only to the right where there's a bit of a difference in these low grade of stenosis, this degree of stenosis, and that here there is an issue. In all these other receiving coronary vessels, an arterial graft is performing much better than a venous graft. So what should be the second graft? Should it be an ITA, a right ITA, or a radial artery? Well, answer was addressed in this study. 1,700 patients, most got a bilateral ITA graft. They did propensity matching to get two groups and compared radial to a beta. So it's LETA, left arterial artery is the radial, or two memory arteries. And the red is two memory arteries. They do better. Unmatched and even matched patients, they do much better if they have two memory arteries. So in conclusion, the recurrence of angina is not rare after bypass surgery. It's hard to say for me, but it is true, it does happen, and it's a difficult issue. The treatment should be no different than with de novo angina. Medication is the first line, and intervention the second line, and probably PCI is for most patients safer and easier than a redo bypass surgery. Still, redo bypass surgery is a good option for many patients. It has become much safer than it used to be when I was trained. And it may be that in this situation, off-pump techniques have an advantage over on-pump techniques. The prevention obviously is the cornerstone of the treatment, and it can be achieved by appropriate medications, lipid-lowering drugs, antiplatelet drugs. There's a new trial coming on that addresses this issue. It's a German-initiated trial that compares different antiplatelet drugs after bypass surgery. And finally, I think bimanual artery should be used in all patients for CABG surgery, when they're younger for the late patency rate, when they're older to use the no-touch aortic technique and to prevent stroke. I'll thank you for your attention.
Okay, so, Doctor.
Great presentation, Dr. Klotz. I have a question regarding your presentation. The problem with the patient after CABG coming with angina is usually a patient with nice lima to the LAD open, okay? But vein grafts with problems going to circ or right coronary artery. You may have frequently an occluded vein graft, total occluded from the proximal anastomosis, and the other vein graft maybe has a bulky and diffuse disease. On the other side, you have accelerated progression of disease proximal to the anastomosis, frequently occluded or diffuse disease, and the distal beds are usually also with diffuse disease, small caliber. Then the problem with redo CABG is that it's a second operation, is an elderly patient, many times over 70 years old, even over 75. The arterial grafts are okay to LAD, and the problem is only one vessel, maybe circ or right, and the risk-benefits ratio for surgery is not optimal, because you are going to revascularize with surgery a secondary territory, maybe an obtuse marginal with a PDA, in a patient that's high risk for surgery. But on the other side, PCI has a problem of vein graft with diffuse disease, and I am an interventionalist, and this is a very hostile segment. You have the risk of embolization, MI after PCI, stents here have more problems of thrombosis and restenosis. And if you want to work through the native proximal vessel, many times is also occluded. Or my question, after all this scenario of this picture, is what is your personal opinion about hybrid revascularization? Because full arterial revascularization is very infrequent. Even in syntax, it's 15%, less than 20%. If you go to the national database in US, it's less than 10%. In Europe, it's less than 10%. I mean that we are still have patients with vein grafts, even today. 1 or 2 vein grafts, and the other grafts are 1 lima, maybe 1 rima also, but we have still vein grafts. Why not to approach these patients with arterial grafts and stents, avoiding a graft that has a patency of 5 years of 50%, which is ridiculous, actually.
A hybrid procedure as an initial approach, is that your question? Well, for the sake of the discussion, I'll take the other position that it's probably the worth of both worlds. The patency rate of grafts is not perfect, but it's pretty good. And you have in that patient both the problem of the complications of PCI and the limitations of a bypass surgery only to 1 graft. I think the key for complete revascularization is also in your hands as cardiologists. I think you should demand from your surgeons that they at least try to achieve a much higher rate for total arterial revascularization. It does come at a longer operating time. It is a little bit more complex, but there are many publications that show now that there is not an increased mortality from that procedure. The operative risk is the same. There may be a slightly increased risk for sternal infection, but other from that, the outcome of those patients is much better. And I think as cardiologists, you should press your surgeons that they do an approach for total arterial revascularization. Now, in some patients, we do do a hybrid approach, usually a staged approach. There are especially right coronary arteries where they're not severely stenosed that we probably just should skip as surgeons. Just do your arterial revascularization on the left side, on the circumflex branches and the LAD, and leave the right coronary artery. Most of those patients will not get recurrent angina from their right, and if they do, it's a very good option to do a PCI there. So hybrid could also be staged. So what I like about the PCI is that you could do a staged procedure. You take the vessel with the highest grade of stenosis, put a stent there and see how the patients do. If it's not doing well, you can treat another territory. So to do a hybrid as a single procedure or a one admission double procedure, I'm not sure where it's going. There are groups who have very good results. I think it's a Danish group that has a very nice mid-cap procedure, Lima LAD, and then they do PCI to the other vessels. I'm in doubt whether that's going to be a good result. And I have to agree that a vein that's sick for 10 years and then we have to treat that, do a re-intervention, it has the name of being a high-risk procedure, but most of the redo CABG we do now are with open limas. We know how to deal with them. We probably just leave them open. We try to do a right IMA from that old lima as a Y construction to circumflex and right coronary branches. It's a complex operation, but it can be performed safely.
We have just a short question from a surgeon, and a short answer, please.
We used to have about 2 redo CABGs every week in the past. And as you showed, is decreasing. We have maybe 1 every month. It's really very striking. And I fully agree, arterial revascularization probably, from our point of view, is one of the main issues, and also medication before and after. My question is, why do you think, even if we have so many data concerning bilateral thoracic artery, why surgeons are so reluctant to use the 2 mammary arteries? It's indeed the problem of the infection but it's amazing how people is still reluctant to use the 2 mammary arteries.
There seems to be a natural reluctance to change in general, and but we're getting at a time where it's almost unacceptable. There is, in the United States, I think there is a litigation issue that patients with Lima vein it's probably easier to manage in the initial period during the operation. They have less sternal infections, they have less issues around the operation. With 2 mammary arteries, you have to look at your driving pressure. So once they get ischemia in the ICU, and you give them nitroglycerin where their pressure drops, they die. So you have to give noradrenaline to keep their pressure up, because usually a driving pressure issue in total arterial respiration. You have to recognize that. And I think in many institutions they have had some issues which were not managed correctly that made them fear. And the final thing is that the operation takes longer. In most institutions, we have an 8-hour slot during the day to do our operations. Lima with 2 or 3 veins, you can manage in 8 hours, 2 cases. Double mammary artery is a challenge. I cannot. I need 4 hours operating time for 2 mammary arteries, and that doesn't work so you need a longer operating time. So there are also financial issues involved, I think.
Well, thank you very much, Dr. Muller.